Dr. Tennant, we were talking about you, and I just can't believe how dedicated you and Miriam are. It's just, we feel so very loved and so very blessed that not only you're for you to do what you're doing and to do each week, we don't take that for granted, nor will it ever be taken for granted. But you have been traveling all day, and here we are. And I'm like, talk
Well,
about dedication.
yeah, well, thank you so much. But just remember, every time I turn on this podcast and I see all of you out there, you're an inspiration. You're kind of energy. You keep us going. Okay.
Oh,
And as
thank
long as
you.
Nice.
as long as I've got good health and I hear that people are getting better each week, I'm in. Okay.
Wonderful. That's wonderful. Thank you, Dr. Tennant. Thank you. And we can go ahead and get started. We have season 6, episode 5 today. So we can go ahead and start if you'd like to take it away from here, Doc. It's all yours.
You bet. Well, thank you, Jamie, and I appreciate everybody holding off for an hour. Well, I made sure that my flights landed and that Miriam and I are here ready to go. And we didn't want to miss this week because, quite frankly, this last week has had a lot of new developments on the scientific front. And it's like everything in science, sometimes they don't always work out, but we've had some exciting news this last week that I want to pass on to you. Also, I've asked Dr. Guess and Dr. Ibsen to pick a favorite subject of theirs to talk about here tonight also. One of the things that's inspired me here and to make sure that we don't miss a week is because our numbers who see this show and who see the follow-up videos continues to increase. And as long as we're bringing a message to the community that's in pain and in suffering, and we know that we're bringing more people in, we need to carry on. And we have had, as I said, this week alone, some very interesting things have happened, which I'm going to pass on to you here tonight. To get started with tonight, though, I want to talk about a subject that's as old as Methuselah, but it has been forgotten, and that is we sit here on the show and we talk about MRIs, we talk about antibody levels, we talk about pharmaceuticals, but you know what we don't talk about enough, and that is symptoms, okay? And symptoms of some things have gotten very important to me lately, and I'm going to tell you why. Each week I read MRIs from around the world, and I answer correspondence, and I examine patients, and I have a lot of sources of input. But one thing is starting to become clear to me. Some of these diseases, particularly arachnoiditis, RSD, and the Epstein-Barr syndromes, these are starting to spread now, and we're starting to run into denial. People don't want to accept these things. They don't want to go forward with what we're learning to help people. And I want to tell you a little story here that happened this week. I received a message from a woman in one of the northern states, and she had been to all kinds of neurologists, neurosurgeons. She was quite ill, and everybody said there's nothing wrong with her. Your MRIs are normal. And she wanted me to take a look at her MRIs because she was quite sure she had adhesive arachnoiditis. Turns out she had a terrible case, very obvious case. Why in the world a radiologist didn't see it amazes me to this day. But let me tell you what my message here tonight, and it's twofold really, and that is we have identified over time 8 major symptoms of adhesive arachnoiditis. And we've now studied this under several different groups, and no one who's had adhesive arachnoiditis has had less than 4 of these symptoms. And I'm going to read these to you. Now, one is whenever I have somebody tell a patient, or a patient says they don't think I have arachnoiditis, my answer is real simple. Here's your 8 major symptoms. If you've got 4 or more of these, then what do you have? Okay, and my pet peeve is when somebody says you don't have this disease, and then, well, what do you have? What is your diagnosis? Oh, we don't have a diagnosis. And what's your treatment? Oh, we don't have a treatment. We're not going to treat something we don't know. And so we have this, what I call double denial, and that is, I don't like your diagnosis. I don't have a diagnosis, and I don't have a treatment. And so, where does that leave the patient and the family? It's really awful. And unfortunately, we've got big medical institutions now giving people that message. We don't know what you've got, and we don't have a treatment, and we're not going to bother to find out or do anything about it. And I think that's a disease that's creeping through the medical system. In other words, we don't like your diagnosis, but we don't have one of our own, and we sure don't have a treatment. Okay? And I think a lot of you can relate to that. Now, what I'm going to do is I'm going to go over the 8 major symptoms of adhesive arachnoiditis. And what I'd like to ask everybody who watches this show to know these. And if you know somebody who has these symptoms, they need to get evaluated for it. I'm starting to come to the idea that there's a lot of people out there walking around who have arachnoiditis and they have all the symptoms, but they don't know what to do about it. And what should you do about it? Know the symptoms and demand an evaluation, get it pinned down. But there's some peculiarities about this disease and the symptoms that are really quite interesting, but they're also specific and should be known to everybody who's an advocate or who wants to help these people who have this disease. Let's go over these 8 symptoms, and I'm going to explain a little of the physiology behind each one of them. Symptom number 1, you got chronic back pain, and it's usually sharp and stabbing pains, and they get worse when you twist or you turn. Okay, and the second symptom is when you either stand or you lay down, the symptoms will either get worse or get better. We call that positional pain. Now, why is this? It has to do with the fact, and I know a lot of you have seen this, the spinal cord ends at about your mid-back, and hanging down are about 24 fine threads we call the quadraequina nerve roots. Now, they're hanging there suspended in fluid. And now, if you get one of them inflamed, or you get one attached by adhesions to the wall of the spinal canal and you turn, it's going to hurt, okay? And the most common place to get adhesive arachnoiditis is right at the lumbar sacral junction. Now, you don't have to know that, but what you do need to know is that's right where the pressure is when you sit, okay? And that's why when you sit and you get pain, you've got adhesive arachnoiditis until proven otherwise, okay? So that's why you get sitting pain, then you need to understand that you've just sat on some Katorolac nerve roots that are inflamed or have adhesions. They're sick. So that's one of the big things about it. You know anybody who gets pain when they sit, inform them what you've learned here tonight. Now, another thing that's very interesting, the Katorolac nerve roots have lots of connections, and it has connections into the skin, okay? Now, what that means is, for reasons that we don't quite understand, but those skin connections to the Katorolac, if the Katorolac is damaged, it's inflamed, it's sick, it starts making that skin feel like you've got running water on it, or maybe an insect on it, or a bug crawling on it, okay? So you know anybody who's got a bug crawling on their skin or water dripping on there, or some kind of funny feeling creeping up and down their skin, you think adhesive arachnoiditis. I don't know anything else that gives you that, okay? So again, you got 2 things here quite specific. If somebody has pain when they sit down and they've got funny, feely, crawly feelings on their skin or water dripping on there, that's adhesive arachnoiditis, okay? I don't care what the MRI shows, you've got it, okay? Now, another thing that this likes to do, the Katorolac, again, has these connections into the skin, and sometimes it makes the skin feel like you're burning. And interestingly enough, the only place it may be is the bottom of your feet, okay? So somebody says, my feet are burning at the bottom, I start thinking Katorolac. That means the Katorolac, again, is inflamed, it's diseased, but it has connections into the skin. So when somebody says they've got a burning skin somewhere, I think Katorolac disease, I think adhesive arachnoiditis. Also, that Katorolac has nerve endings that go someplace. It goes to your bladder, goes to your bowel, if you're a male, to your penis, to a woman, a vagina, and it goes to your legs and your feet. And it also goes to your stomach sometimes. Now, what am I getting at? There's about 24 connections between the Katorolac and the bladder. If you've got adhesive arachnoiditis, you're almost always going to have some bladder symptoms. Now, what kind of bladder symptoms? Well, maybe you can't hold your water. Maybe you're going all the time. Maybe you can't get it started. Maybe you can't get it stopped. But you're going to have some bladder problems. And in fact, I often say if somebody does not have bladder problems, they don't have adhesive arachnoiditis. So again, you've got bladder problems and back pain, you think it's arachnoiditis, okay? Now the bad one is the Katorolac controls your nerves also that go into your bowel and into your vagina or into your penis. So you start getting funny feelings in your rectum, your vagina and your penis, your scrotum. You start thinking that's the Katorolac that has a disease in it because those nerves were connected there. Now, a lot of times people don't want to talk about that because nobody likes to go around talking about their rectum or their vagina or their penis, obviously. And so, but if you have it, and you've got to remember that's part of this disease. Now, the bad one that I'm always harping about is that the Katorolac has the nerves, the big sciatic nerves and the big femoral nerves that go into the leg and the feet. And once they get disease, you start developing weak feet. and some paralysis. And so one of the treatments for adhesive arachnoiditis is based on trying to prevent paralysis, trying to keep the Katorolac nerves intact so you don't develop paralysis and weakness of your legs and your feet. Because once that starts happening, and if you happen to be one of those people, you've really got to have an aggressive program because I've seen people with this disease be walking on Monday and paralyzed in bed from the waist down on Wednesday. So that paralysis can set in awfully fast, and people have to be aware of that. Now, lastly, and here's the other one that's really funny, and doctors don't understand this, patients don't understand it. Adhesive arachnoiditis is really a little mass of Katorolac nerve roots in an adhesive ball inside the spinal canal. What does that do? It interferes with spinal fluid flow up and down the column. So what does that do for you? It gives you symptoms above the neck. In other words, you need a checkup from the neck up. Now, what kind of symptoms are we talking about? Blurred vision's one, runny nose is another, tinnitus, dizziness, headache. In other words, it's hard to believe that this disease can burn your feet and give you a headache at the same time. And so these are the symptoms. Now, my pet peeve is when somebody tells me they've gone to their neurologist, their radiologist, they all tell them they don't have adhesive arachnoiditis. I want them to pull out the 8 symptoms and go over them. In other words, if you have the majority of these 8 symptoms, I don't care what your MRI shows, you've got it. Now, one of the problems we have in science is that the MRIs are not quite as easy to read as one thinks. Looking at all those nerve roots on end or on the side, they sometimes don't show up very distinctly as to whether you have the disease or not. Unfortunately, we have cases in which are what we would call equivocal. We're not certain that they have adhesions there. We're not certain how much disease is present. And so we have this unfortunate situation that we may have to say the MRI is equivocal, but if you've got the symptoms, you've got it. In other words, the symptoms are not being given enough credit in diagnosing the disease. That's why I'm talking about it here tonight for not only people who have it, but if you know somebody who has it, that's what you need. And anybody who wants to get a list of the 8 symptoms, it's on our website. We'll give it to anybody. It's in all our books. Give it to your doctors, give it to your nurses. I just think that the country and people with back pain, everybody with chronic back pain needs to have a set of these symptoms and know whether they may have progressed to adhesive arachnoiditis. And secondly, when your radiologist and your neurologist and everybody says you don't have the disease, but you've got the symptoms, the message is real simple. If you say I don't have it, then what do you say I do have, and what are you going to do about it? And a patient not only has the right, and so do the families, mainly the families, you have a right to have it. If a doctor doesn't like another doctor's diagnosis, they're obligated to give you their diagnosis and their treatment. This idea in America now that you can just have doctors disagree and not give a diagnosis and not give a treatment is unethical, it's inappropriate, and it's dangerous. Okay? I disagree with doctors all the time on what they have, but I'm going to give them my opinion on what they have and what I think they ought to do about it. That's what a doctor is obligated to do ethically, and I think I'm calling this out right now. If you don't like this diagnosis, what's your diagnosis and what do you want to do about it? And I'm calling on the families and the patients to call them out on this because we're the only ones who will. I guarantee you that their insurance companies aren't going to call them out. The medical boards aren't going to call them out. Their hospital's not going to call them out. In other words, this idea that you can just ignore symptoms and complaints and disease and not treat somebody or give a diagnosis has to go. But us folks down here at the bottom, we have to force them to do this, okay? And Jamie, you got the right idea, and I hope that everybody really discusses this. You got it? Okay, what I wanted to talk about next, and some of you may have seen our latest bulletin. In our latest bulletin, it's about innovations with the hormonal substance palmitoylethanolomide, abbreviated PEA. And I'll be using just the word PEA. Now, there's something about this that is quite interesting. PEA was discovered in the body clear back in the 1940s, but nobody knew what it did. But in recent years, science has shown that PEA is a natural hormonal substance that the body makes when you get inflammation or pain inside the nervous system. And it appears to be, if not the major, one of the major things that the human body uses to try to heal spinal cord and brain tissues. Okay? Now, we've been recommending it for people for the last 2 or 3 years, and they've been using it oftentimes for acute pain problems, flares, exacerbations, and a lot of the products have PEA combined with quercetin or serrapeptase or with luteolin, and those have been great compounds for people to help with their pain. In other words, they could use it for flares or what have you. Now, in recent months, we've had a lot of people start using it on a regular basis. And most of the people that I correspond with have been using it, at a dose of 300 or 600 milligrams a day. But then just recently, we've had something happen which really is important. We have had a famous pain professor in Europe, Professor Keppel, and a man here in this country by the name of Jacob Teitelbaum, who I consider the world's foremost authority on biochemical pain treatment, have both found out that PEA at a high dose taken for several weeks or months reverses central pain. Okay? Now, you might think, well, so what? Let me tell you what so what is. This is the first time we have had anybody report anything in any kind of a scale that helped reverse central pain. Okay? Now let's talk about what do we mean by central pain. Central pain, again, is a diagnosis. A lot of the old timers in arachnoiditis used to talk about it as a secondary pain. But central pain is the pain that gives you constant pain. It gives you your hands and your feet are going to be cold. And then you have periodic elevations of your blood pressure, your pulse rate, and your sweating and your temperature. And so ask yourselves right now, is my pain there 24/7? Are my hands and feet cold? And do I have occasional episodes of high blood pressure, high pulse rate, sweat a lot, or have my temperature go up? If you do, then you have central pain. Now, the cause of central pain is now known. Again, this is a scientific advance. And what we now know is it's caused by inflammation in cells in the brain called glial cells. And these glial cells get inflamed and become dysfunctional. And their normal job is to shut down pain signals. When the pain signal comes in from your knee or your spine or your head or your muscles, it shuts it down. Well, they no longer are able to shut down the pain signal, so your pain is constant. Okay? Now, in order for you to get cured or even to permanently reduce your pain, you've got to have some healing of your glial cells. And up until these reports of PEA, we have no such reports. Okay? So what people need to know is, despite all these agents out there, the gabapentins, the opioids, the ketamines, the stimulators, the pumps, the surgeries, all of these things, not a one of them is even suggested to try to reverse central pain. But for the first time, you've got Professor Keppel and you've got Dr. Jacob Teitelbaum, two people that you just have to work with and who know what they're talking about. I have total confidence in these gentlemen, and I've done enough work along with PEA to know that I think they're on the right track. And here is what they have determined. They have determined that if you take a dosage of starting off with 600 milligrams in the morning and evening for 1 month, and then they recommend going to 1,200 milligrams twice a day for the next 2 or 3 months. And I am now recommending that all people who have adhesive arachnoiditis or have central pain, whether it's due to the CRPS, fibromyalgia, severe arthritis, EDS, or whatever it is, if you've got central pain symptoms, I'm recommending that you go on their protocol. You can get PEA without a prescription. It's available from several companies in 300 and 600 milligram capsules. It's quite inexpensive. There are no side effects. And I'm now recommending it as a first-line treatment for adhesive arachnoiditis. Okay? And now let me go on a little further with this. Let's say that this is not perfect, and we may have some of you out there says, oh, I took PEA for a month, it didn't do a thing for me. Well, it's not going to work for everybody. Nothing does. However, they have enough good data to convince me that everybody needs to give it a try. You've got nothing to lose. Now, let's say that you can take this treatment and you reduce your pain 30-40%. In modern medicine today, what we've learned is if we get one good base drug, like we do with, say, Medrol, we get one good base drug that controls things, then we can add to it, and we can kind of put together a cocktail or a multi-purpose packet, if you will. And I'm now convinced that we are on the road to some cures, okay? But in order to get cures from things like adhesive arachnoiditis or CRPS, fibromyalgia, severe arthritis, severe neuropathies, we've got to deal with this central pain issue. And if PEA can help us reduce that 10%, 30, 40, 50%, we can add some things to it and put together a package, because I must tell you, I'm giving this show tonight for the first time and thinking, yeah, cure may be possible for a lot of people with these diseases if we can catch them early enough, okay? But PEA is definitely going to have to be part of the equation. So I'm very excited about it, highly recommending it. Now, let me tell you something else I did this week. No promises, no great claims, except I've changed protocols. Dr. Purcelli, who runs our foundation's research unit, along with Dr. Lloyd Costello, another associate, and I, this week, changed our starting protocol for adhesive arachnoiditis. Our standard protocol has always been Katorolac plus methylprednisolone plus symptomatic pain medications. That's been the basic protocol. Well, we're still using symptomatic pain medications. You got to have those. But rather than start people with Medrol, that's a corticosteroid, and Katorolac, guess what we started new patients with this week in our studies? PEA and ivermectin, the two together, because we have some other studies out there now that show that the Epstein-Barr virus may be one of the factors causing the glial cells to become dysfunctional. And so again, we're starting right out trying to find partners with the PEA to try to get people's pain permanently reduced. Okay? Now, I want to go on to another subject here for a moment. The people with severe pain, they have a tendency, and rightfully so, to only focus on today. They need pain relief today. They're miserable, they're suffering, they want pain relief today. They need a higher dose, they want a different drug. They're not interested in hearing about the future. Now, that's a mistake. And for those of you who are families out there or have loved ones that you're trying to help care for, we need to enlist your help to be thinking about permanently reducing pain. Okay? Now, there's another new study just out in the last few days, showing that people with severe pain do have serum deficiencies in vitamin C, B12, D, and magnesium. And we have known for some time, and I've recommended for some time, that people take these vitamins and minerals. Well, I'm stepping up my recommendation. And I'm going to be recommending that everybody with adhesive arachnoiditis and these other terrible intractable pain conditions, I think you need to be taking vitamin C at a dose of 2,000 milligrams in the morning and night. You need to be taking a tablet of B12 each day. You need to be taking a capsule of D or D3, and you need either magnesium, zinc, or selenium, some mineral to go with it. And now nobody wants to hear about taking vitamins and minerals because they think that's just kid stuff. I don't need it. I need pain medicine. Well, let me tell you, these vitamins and minerals, they do several things. Number one, they make your opioids work better. The studies are pretty clear that these nutrients help the receptors function better. So when you're taking your vitamin C, your magnesium, your zinc, your B12, you're going to have a better effect from your opioids or your ketamine or whatever you're taking. That's number one. Number two, there are studies showing that when you do take these vitamins and minerals, you, number one, keep the Epstein-Barr virus from reactivating. And number two, you also make the tissues nice and healthy so the virus won't colonize in these tissues. You're going to hear me talk a lot about Epstein-Barr colonization because that's what causes the virus, when it reactivates, settles into colonies in tissues and gives you the cancers. And if it doesn't give you a cancer, it may just destroy your tissues like your glial cells or like your arachnoid membrane. And so colonization of the virus is a major thing. And that's also why ivermectin has started to become very popular. And I'll be talking about ivermectin more in some of the future shows, because I now believe that it's a comer, it's here. And I'm hopeful that plus PEA may be a real winner. Don't know yet, it's early, but we are doing the studies that we have a good idea that it just may work well. With that, what I'd like to do now is to see if Dr. Guess is available.
Dr. Tennant, I am here.
Okay. Scott, we talked earlier today. We've been together a long time, covered a lot of ground on a lot of subjects. And I think you indicated today you were going to do a little talking about palliative care. And
yes.
You're an expert in that. Let me just say one thing about palliative care. When we're dealing with these terrible intractable pain conditions, we have two big fundamental classes of people. Those people who are still ambulatory, they can walk, all their muscles function, they can take care of themselves and do their activities of daily living. Then we've got another group who are at least bedbound or housebound, partially paralyzed, and are going to have palliative care. And we want both groups taken care of. So anyway, I'm going to turn it over to you, Scott, to tell them about palliative care and anything else here tonight you'd like to educate that you think we need our people to know about to help themselves.
Thank you, Dr. Tennant. there's not enough time in the remainder of the week for me to stand on each one of my soapboxes that I like. You asked me to come up with my favorite one, and my favorite one is palliative care because I feel it's not brought up enough. And so many people, when they hear that word, palliative care, they go, "Oh, I'm dying. I'll be dead in 6 months." That's not the case. Palliative care is a one of the categories of medical care. We can cure, we can prevent, and we can palliate. Basically, that's all we can do. Everybody, when they hear palliative care, immediately think hospice. And that's a very small subset of palliative care. It is not the whole kit and caboodle. And what throws a patient into that category of palliative care? It's pretty simple. If we have a disease or a condition that's not curable with today's medical knowledge, and that one word, today's, is one of the keys, because 15 years ago we couldn't cure non-Hodgkin's. Well, maybe longer than that. There was a time when we couldn't cure non-Hodgkin's lymphoma. Now we can. There are a number of cancers we can cure now. So with today's medical knowledge. And so maybe we'll come up with a cure later. I mean, look at what we spoke about this evening. Dr. Tennant is looking at a potential reversal of central pain with high dose PEA. So maybe we'll take central pain off of the palliative care list in a number of years, or maybe even months, who knows. And why this is important, because if you have a condition that can't be cured, instead of being just going down that road trying to constantly find something, and we're not going to give up on finding a cure or treatment, but the benefits of being put into the palliative care basket are twofold. And primarily the benefit is for your prescriber, your doctor, because if you are taking opioids and you can't get away from them. 15 years ago, when we had the height of the pain management era, and opioids dosing as high as needed, we created a lot of legacy patients who do very well on high dose opioids. Well, now opioids are a bad word and we can't use them anymore. But for those who can still have opioids and still use opioids, people who are in palliative care is exempt from the CDC guidelines and the morphine equivalent limits. And they're also exempt from most state, at least the state guidelines that I'm aware of, primarily California. You're exempt from those guidelines. So your doctor gets some protection from persecution from the regulatory agencies and the powers that be. And it's just another type of care. It is not a death sentence. And that's probably the one thing I really like to emphasize, because people are afraid to go down the palliative care road because they think that's the end of the road, and it's not. Let me give you some examples of other palliative care conditions. Diabetes. We can't cure it yet. We can manage it or palliate it with insulin and the new the GLP-1s and all that. We can make it livable with, but we can't cure it. We can't cure high blood pressure. We can't cure heart disease. We can't cure multiple sclerosis. There's a number of things that are, people accept all the time that we can't cure that are palliative. Pain is one of them. And unfortunately, it's gotten a bad reputation because of the opioid overdose epidemic. I encourage everybody to get your doctor to look at palliative care more deeply and get into the, get yourself diagnosed with palliative care for their protection and for yours. Unless you have anything more to add, Dr. T, I think that's about what I've got.
Thank you, Scott.
Yes, Scott, can I ask you a question?
Absolutely.
How both should a patient and a family and a primary care doctor or nurse practitioner could you give any criteria for when they should determine and label the patient as being in palliative care? I'm not talking about going to the government program now. I'm talking about
Oh.
in the office and in normal primary care. How do we determine who should be labeled as being in palliative care, and should that labeling be in their chart?
It definitely should be in the chart because that gives, it opens up opportunities for the patient and it certainly opens up protections for the physician. And palliative care you should be labeled as palliative care at the time of diagnosis. If you're diagnosed with fibromyalgia and we know it's incurable, if you're diagnosed with Ehlers-Danlos, we know it's incurable. There's no reason to wait months and years to decide your palliative care or when, in your last 6 months of life. That's hospice. Diagnosis is made the time that you establish that what the diagnosis that you have is an incurable condition with today's medical knowledge.
Also, as a pharmacist, should they, when the doctor writes the prescription, should he put right on there palliative care?
Yes, they should. And that's one of the advantages, and I know a few people don't like them, but that's one of the advantages of the whole electronic prescription system, especially for controlled substances. You link the diagnosis right to the prescription, and that does help the pharmacists because it saves us a phone call. We often have to call back and say, hey, what are we treating here to protect us as pharmacists? So yeah, just link it right on that electronic prescription.
Uh-huh. Do you have any thoughts if somebody enters palliative care, chances are they can't work, can't go to school. What should they do with their life if they're going to be in palliative care?
They do everything and anything they can do. It doesn't prevent going to school. It's not a diagnosis of disability. It's a diagnosis of we can't fix this yet. So if you're going to school, you're working, keep doing it because being a palliative care patient does not interfere with your life. It just gives you a little bit more opportunity for treatment.
Yeah, we just had flash on the screen something that is happening, and that is in some cities and some parts of the country, there is no such thing as a palliative care organization left. Nobody claims they do it formally. So how do we get the primary care doctors, nurse practitioners, families to start labeling them people correctly, because they can get insurance coverage, they're exempt from regulations, they can get higher dosages and different dosages. Do you have any recommendation to doctors, nurse practitioners on what they should do?
It's got its own ICD-10 code. You just have to put it in the chart. There is a couple of national organizations of palliative care. I'm a member of one of them for palliative care pharmacists. There's one for patients, and they're out there. But there doesn't need to be a formal organization that supports it. It has its own ICD-10 code. It's recognized as an official and official diagnosis that can be used and is billed.
Basically, let's to warrant that diagnosis of palliative care.
Oh, I'm sorry, I've got it. It's Z51.5. That is the ICD-10 code for palliative care. Z as in zebra, 51.5. Every person who has a condition that's not curable, like arachnoiditis, adhesive arachnoiditis, EDS, ALS, the list is quite long. The doctor just needs to put Z51.5 in the chart, and many protections come into place.
That's right. Norm, I see you're on there. You got a comment about palliative care?
Yes, I wanted to first speak to you about one of the things you pointed about, spoke earlier about diagnosis and your doctors disagree and stuff, and it's so important. And I wanted to just add a conjunct to it and put it in writing. And oftentimes we have, and this applies to pharmacists too, that you go to the pharmacy and he says, well, I feel uncomfortable filling this prescription. And one of the most important things that if you're going to have a corresponding responsibility, then Mr. Pharmacist or Dr. Pharmacist, then that responsibility is put it in writing. And I think you're ever so right that this thing about when doctors disagree all the time, and we need to put it in writing. Well, again, that's part of an expert's or a second opinion's corresponding responsibility. That pharmacists are going to take that role up. I think that's ever so important what you said here today.
Yeah.
It backs up what we've been saying. And in terms of palliative care, again, that's the greatest the greatest tragedy in medicine is that we've allowed law enforcement to dictate medical protocols and dictate rather than clinical judgment, medical judgment. We have these law enforcement goons, if you want to call it, want to totally eliminate control the medical profession, and saying that palliative care is a hoax and an easy way for people to seek drug enforcement. That's all I have to say. And thank you very much, Dr. Tennant, for
Norman,
being. You're a wonderful
yes,
person.
let me ask you a question.
Yes, sir.
In general, are you saying that law enforcement almost rejects the concept of palliative care or the need for humanitarian care in that state?
That's exactly what I'm saying. I'm saying more that law enforcement has no business in dictating the practice of medicine. They don't have the expertise, and they don't have certainly the knowledge. And we wrote about this in our recent article in You're Within the Norms, the great work of Dr. Neil Ernon, the work of Mark Ibsen, and things, talking about a particular program's even set up that very few people know about. It's called Nemesis, or Isolation Force. And what this program does, it screens out the anomalies, that what they call the anomaly, those things that make common sense. People coming into treatment, people coming infrequently for treatment, those things are criminalized, and it is prosecutors and law enforcement that then takes that to court and use it against them. In fact, we pulled up a case of yours, Dr. Tennant, and we were able to demonstrate through a comparative analysis that this Nemesis program, this Isolation Force program, was used against you, it was used against Dr. Christensen, it was used against Mark Ibsen. So you're absolutely correct. The clear bottom line are here, and you've said this, they have no business dictating the nuances or the dynamics of medical care and medical program and medical disease, because as you pointed out, disease is a dynamic state. What works for one doesn't work for all. When PEA, it may work for some and it may not work for other people. That's what happens. That
Sure.
happens in all diseases and disease states. And what is never discussed, and you point this out so eloquently, is the disease and the disease state of the patient. Law enforcement is hands up, don't shoot, about this, what we call harvesting, so that a guy with like Forrest. I'll give you a good example. Tennant, MD, is more valuable to prosecute and can get me up to higher legal than Forrest in the hood. You see what I'm saying? Your MD degree, or your pharmacy degree makes you a better the target, and then not what you do, not what you're practicing. It makes you a target because now law enforcement can take medicine. And in fact, there was a statement that was made 30 years ago, and it said they called it the least. I have it right here. It's called the least compliance is what they go. In fact, it's what they go, least regulatory non-compliance compliance, and that came from a prosecutor named Donald Zerendow out of Massachusetts. Least, and so what they take a regular medical procedure and lower it to lower the standard to a crime, lower the standard of of a medical program to a crime, and then they indict. And this is when we do it. And so I don't mean to be elongated here, but the point is this is how we're being targeted, and and we're being, and palliative care. Dr. Geis's palliative care is being overridden. And what the sad part is, what Dr. Geis points out in this forum, when you get to that comedy forum in the courtroom, it's win at all costs, and that doesn't mean anything. As Dr. Geis is out here trying to hustle a buck, make some money, illegal gain. He bought a car, he bought a helicopter, and we're going to send him, and that's what he gets indicted on. So yes,
Yeah.
law enforcement is digging. I don't mean long. Thank you very much, Doctor
Norman, again, let me also say one thing before
Yes,
you
sir.
sign you off here.
Yes,
On
sir.
many a day, I've seen your writings, and I want you to know you've cheered me up on many days. When I was a little down, I've seen some of the things you've written. I don't know whether to laugh or cry, but I sure appreciate what you're doing. Keep
Oh,
it up,
stop.
buddy. We got to
Oh,
have you.
stop it.
Okay.
Yeah,
All right.
thank you.
Look,
Thank
where's
you.
Dr. Ibsen? Let's get him in here now.
Hi there.
And Norm, keep up the good work.
Thank you. Thank you so much.
I think we need to do some palliative care on the definition of palliative care. I love your definition, Dr. Tennant. I don't accept your diagnosis, but I'm not giving you an alternative. That's happening regularly. And it's happening behind the pharmacy counter too. I'm not comfortable, which means I don't want to give you that medicine. Well, do you have another suggestion? What else should I do? I have a patient in Kentucky who just got cut off from Kroger because she's been using the medication for 8 months, and they said that's too long. We've been taking a risk filling your prescription for 8 months. We mustn't continue it. But the 8-month nature of the continuance of the prescription indicates that it's safe. The patient's still alive month 6, 7th, and 8th. So how can it be dangerous if the patient's still alive and still coming to the counter to get the next month? How could you not be comfortable with that?
It's irrational.
It's completely irrational. And for everybody on today, I have a statement I want to make to you. I'm going to say it fast and then I'm going to repeat it slow. Okay? Those of you concerned about a palliative care diagnosis. If you get a terminal diagnosis, it's your second terminal diagnosis. What's the first terminal diagnosis? Human existence
Earth.
is a sexually transmitted disease that's uniformly fatal. So after that, everything is palliative. So I'm going to repeat that slowly so you guys can write it. Human existence is a sexually transmitted disease
Yeah.
that is uniformly fatal.
Can you
So
say that again?
we're all already dying. Everything we do is palliative. From our diet to our genetic structures to our managing our hypertension. I have heart disease in my family, and I had a surgical procedure that was palliative. I had a bypass surgery. I'm still here, and yet it didn't cure my coronary disease. It just rerouted the plumbing. And those of us who think we're all highfalutin and erudite and making diagnoses, it's basically some of us are just plumbers. And the palliative care for a plumber is a plunger. So those of us who think we're all fancy and everything like that, we could actually simplify things a lot. And palliative care is sort of like pornography. You'll know it when you see it. Anybody can make the diagnosis. Everybody's afraid to write down palliative care. Somebody might criticize you. Well, let them come up with something better. I love that idea, Dr. Tennant. I was asked to kind of give an update today. I have some good news and some bad news about my case. The good news is I did a text or a post in April when I was in Philadelphia attending Dr. Anand's trial. And in that trial, by the way, sorry for the diversion, Dr. Timothy King must have said over 50 times as he looked at the practice of Dr. Anand, he would say that is not the practice of medicine. But what the defense never did is say, well, do you have an example of what the practice of medicine does look like, Dr. King? So, yes. That's not okay. That's not okay. That's not okay. Well, then nothing's okay at some level. And so we have to kind of in the courtroom focus on that. So I've been, I want to tell you my good news. The good news is I got a subpoena. I didn't get a SWAT team. I didn't get a search warrant. They didn't come up and disrupt my house and leave the front door open like they did with you, Dr. Tennant. And I think that that's a sign of hope. Maybe I challenged them, and they're taking the bait. And so I got a subpoena, and that subpoena has been satisfied. In other words, we produced the documents that they wanted. But I wanted to present to the grand jury, and I haven't had that opportunity yet. And I think that's good news too, because if you've paid attention to the rest of the culture's news these days, there are several things happening around prosecutions, including selective prosecution, vengeful prosecution, I guess, or I can't remember the term now. And other situations are happening where grand juries are standing up and saying, we're not going to indict the sandwich throwing guy in Washington, D.C. You can't indict you can indict a ham sandwich, but I guess you can't indict a Subway sandwich. So to some extent, having a grand jury waiting to hear from me is a good thing. That said, it's been delayed, and I've been kind of waiting for my performance, and it's frustrating and vexing to wait this long. So I'm going to illustrate this by a image. I've got the blues, and I've got them really bad. And I'll get through it, but I want you all to know that we all have ups and downs. I'm in a down period myself, and kind of struggling with the oppression over me. Time will help. And I'm just, please be patient with me as I don't participate very much while I'm doing a lot of self-care stuff. And some of my usual self-care routines are failing. And so I have to find new and better ones, sort of like PEA and ivermectin. Okay, I need some new therapies too. I'm taking suggestions. But that's all I want to share today. There's no bad news. And as my attorney says, justice delayed is justice. So I'm praying, got my fingers crossed that things will work out. The other thing I did is I prepared a presentation for the grand jury with a lot of help from Susan. We did a rehearsal and recorded it. And I can't share that until I can appear before the grand jury. But when you see it, you'll be moved. It's quite profound. So I think we can win, and I intend to. So that's all I got. Thanks.
Right. Mark, on maybe a little bit different subject, you will recall that within the last month, an article appeared in the Journal of the American Medical Association, in which we had an academic person fundamentally say we shouldn't prescribe opioids for long-term care because we don't have control studies showing a benefit. Okay?
Yeah.
And let me tell you again, and Norm, maybe later, Scott, everybody may have some opinion. What I find incredible about this country is that I cannot find a written document by any of the people criticizing any of this with the criteria on who should get opioids for long-term care. No one is willing to put in writing what is the criteria. The last time we did this was when we passed the Intractable Pain Act clear back in 1990. Would you want to make a comment? Where's all these people, all our critics? They don't want the opioids. Well, who's eligible? Well, I mean, we're talking about a total absence of anybody. No one's willing to step up to the plate and say these people are worth taking opioids as a trial.
Yeah, that was vexing to read that. And I think it's just bandwagoning and people kind of jumping on the anti-opiate bandwagon. The question I have for them is that we haven't proven Chinese medicine works, but there's 10,000 years of history of it. And you can't do a double-blind placebo-controlled study to demonstrate that acupuncture works or other Chinese medicine or Ayurvedic or any other healing modalities because they're all subjective. And you can't do a double-blind placebo-controlled study longer than, I think, 12 weeks in medicine, according to the FDA, because it's always been unethical to deprive people of an opiate because it is the gold standard for pain relief. So by the fact that it's a gold standard, indicates that we couldn't ethically do any studies longer than 3 months. And so this disingenuous statement that there's no proof that opiates work is completely BS. And the number one thing that happens in the exam room, and this is why I'm standing so strongly for the sacred physician-patient relationship, is that every interaction between a doctor and a patient is an opportunity to utilize the scientific model. And the scientific model is really basic, and it's from the Renaissance, and it's basically you make a hypothesis, you test the hypothesis, you revise your hypothesis based on the results of the test of your hypothesis. And that is the physician-patient relationship right there, and that is scientific. And it was good enough for Newton, and it's good enough for Semmelweis, and it's good enough for Henry Osler. So it's good enough for me, and this whole, frankly, and then this is really out there, we bow down to the double-blind placebo-controlled trial like it's a golden idol. And you know, I don't need a weatherman to tell me if it's raining. You know, I don't need a chef to tell me I'm hungry. I certainly don't need you know, a fire hose to let me know that I'm thirsty. So all of us who are eager to appease some medical higher power, it's sort of, my attorney says this: you cannot propitiate an evil God, which means don't try to appease people who are ignorant. You can't do it. So in some ways, we have to shift the tide, but at some point, it's between the doctor and the patient and what works for them, which is key for every patient saying, "Doctor, how can you help me? I need your help. What are you going to do to help me?" And in the 1880s, doctors went to the house in a horse and buggy, and we didn't have much. We held their hand while they died. And we loved them, and we consoled people, and we went to the funeral, and we were connected to patients. And now we figure, like, well, I don't want to touch that because I'm going to catch it, and we don't want to touch opiates because we don't want to catch the opiate disease, which is jail. And I think that if we can articulate that more and more frequently, and particularly outside of our little bubble that we're all in right now, then maybe we'll make some progress.
Absolutely. In other words, what you're saying is we don't like opioids, but we've got no alternative, and we're not going to help. That's the sickness.
Right. Yeah, my patient in Kentucky that I've been freaked out about. You know, Kroger stopped filling her prescriptions. She's screwed. She lost her pain doctor. She has a cancer doctor. The cancer doctor is afraid to prescribe for her. So what does she do? He says, you got to go to a pain doctor. She goes to a pain doctor, and the pain doctor says, "Oh, we're interventional pain," as if that's a higher level. Like opiates is minor league and interventional pain is like major league. You know, that's just such bullshit, particularly those of us who have had interventional pain procedures. There's not a lot of people that are having interventional pain procedures the rest of their life. They finally give up on them.
Yes. Well, what we've talked here tonight is all the irrational, illogical, inhumane, I mean, ridiculous. If they weren't so serious, they're laughable. Omissions of what's going on. And we will continue to talk about them. Okay.
Yeah. Thank you.
Not stop talking about them, because until we have a wealthy country, and heavens to Betsy, we have enough resources to make sure that no one has to live their last few months or years in pain and suffering or die in pain. But that's what we're doing. I don't think that speaks well for society.
It does not.
And
No, it's not.
we're going to keep talking about it. Okay.
Thank you. Thank you
for everything. And no, I like what I've heard tonight. Again, I want to thank everybody who's been here. Jamie, you put together again good crew tonight. Scott, great words on palliative care. Norm, always words of wisdom. Mark, hang in there. We're with you, buddy. With that, we'll see you next week. Good night.
Good night.
Good night. Good night.
Thank you all so much. Thank you for being with us, and you are not alone. We hope to see you next week. Hang in there. God bless you all. Thank you.
Good night.
Good night.
Good night.
God bless y'all. Good night.
Good night.
Great shows. Great shows. Thank you, Jamie. Thank you, doctors.
Night, guys.
Good night, everybody.
Where did I get out of it? There we go. Night, Jamie.
Good night. I love y'all so much.
Love you guys.
Love you too. Stay alive.